Excellent talks. Great work, Dr. Kachiaguera. I will say just that we work very closely in partnership with our epileptologists too to help manage those seizures when they occur in patients. And in the long term, the risk of seizures is low overall. So hopefully we can work together as a team to try and get that better for patients. So, but I'm sorry that your child is having that. Our next speaker is Dr. Smathorn Thakolwiboon. He's an expert in MOGAD. He was a previous fellow with us, and he works in the Mayo Clinic health system in the La Crosse area, and he's been very involved sending many patients over to us for some of our clinical trials. And he's going to talk a little bit about the spinal cord today and its involvement in MOGAD. So welcome, Dr. Thakolwiboon.
Yeah, thank you very much, Dr. Thank you very much, Dr. Flanagan, for the very nice introduction. So it is my pleasure today to be a part of the US MOGAD Patient Summit at Mayo Clinic. Today I will talk about how MOGAD affects spinal cord. So first, what is spinal cord? Spinal cord is like this highway in your body. It's like I-90s of your bodies. It carries a message between your brains and the rest of the bodies to help our bodies working. For example, it carries the sensations from our bladder when our bladder is full to our brain. So brains know we need to go pee, and then the brain sends a signal to the spinal cord, tell our muscles to get to the bathroom and go pee. And spinal cord, we have different regions, and each region is responsible for different part of the bodies. We have cervical spinal cord that's responsible for our arms and upper chest. And thoracic spinal cord, responsible for the most part of our trunk. Lumbar spinal cord, most of the lower extremities. And cervical spinal cord, some part of the lower extremities and also in perineal area. And then in our spinal cord, we have two regions, white matter and gray matters. So white matters is like a highway that carry the informations. And gray matters is like a processing center or organizing centers that help the highways going. And for the white matter, we have ascending pathway, the pathway that going up to the brains, and descending pathway, the pathway that going down from the brain to the different part of the bodies. And each track has different signals that it carries. For example, for the tracks in the back of the spinal cord is carry vibratory sensation and position sensation. So it's important for our balance. The tracks on the side of the spinal cord carries the pain sensations to the brains. And for the descending tracks, we have the tracks mainly responsible for the motor commands throughout the bodies, and also reflex and also autonomic controls that go to your hearts, bowel, and bladders. And then how MOG antibodies affect the spinal cord. So I know everyone knows that MOG stands for myelin, oligodendrocyte glycoproteins. And myelin is like the road surface. Oligodendrocyte is like an engineer that keep the road maintenance well, have a smooth surface. When our immune system become overactive, the MOG antibodies trigger the immune cells to attack myelin or oligodendrocyte. So the road surface got damaged or the engineer got damaged. So we cannot connect information well between brain and the rest of the body. This is why we have the symptoms. And now, when we have the symptoms, and what happens when the MOG antibodies attack the spinal cord? We call it myelitis. Myelitis is mean inflammation in the spinal cord. And myelitis is the second most common type of attack in adults with MOGAD. It may be less common in the children. And myelitis sometimes it can occur in half of the patients just alone. But in the other half of the attack, myelitis can be a part of the brain attack or come with the eye attack as well. And what are the symptoms, or how do we feel if we have spinal cord attack? We may have a weakness because the motor pathway got affected. The motor commands doesn't go well from the brain to the muscles. Sensory loss. When our sensory tracts got affected, the loads got blocked, so the sensory signal cannot go up to the brain. Bowel and bladder dysfunction is quite common in MOGAD compared to multiple sclerosis. Or even sexual dysfunction can occur in MOGAD, and it is very common as well. And in MOGAD, spinal cord attacks are often severe. We can see that in this graph, almost like more than 70% of the patients need cane walker or wheelchair, and up to 1/3 of the patients need wheelchair during the attack nadir. And then how does it look like on the MRI? Spinal cord in the MRI is also extensive as well. It usually involves more than 3 vertebral segments. If we can see the yellow arrow, we can see the lesion is quite long. It's involved like 1, 2, 3, 4, like vertebral segment in this picture. It can cause swelling in your spinal cord. It can involve gray matter, and usually it can involve clonus as well. Clonus is the end of the spinal cord, where it's responsible for like bowel and bladder functions. This is why bowel and bladder dysfunction is so common in MOGAD. And like Dr. Kasekura said, almost 10% of the patients can have normal MRI at the initial, if we get an MRI early on. And similar to the brain, MOGAD spinal cord lesions can resolve in the follow-up MRI as well. After 3 or 4 months, MRI may come back like nothing happens before. And this is different from aquaporin 4, NMOSD, or multiple sclerosis. And how do we treat spinal cord? And treatment of the spinal cord attack, timing is very important. So time is spinal cord. So first, we need an early acute treatment, either by hydrosteroids, and in some severe cases, we may do plasma exchange and IVIG along with steroid as well. And after acute treatment, we need to prevent the new relapse. And if it is the first attack, we usually do like prolonged steroid tapering. And if it is a relapsing case, we may consider some steroid-sparing treatment like rituximab, which is not so good in MOGAD, and we have like a lot of acute treatment that we'll find again cover in the later section. And lastly, rehab is very important. We need to start rehab as soon as possible, as soon as the patient medically stable to be able to get rehabilitation. And we should do it aggressively in the first 3 months because it is a golden period for the recovery. And anyway, despite 92% of the patients respond well to immunotherapy, however, residual symptom is very common. And we can see that bowel and bladder dysfunctions is about 83% at the nadir, and about 44% of the patients had residual bowel and bladder dysfunction even after immunotherapy. Erectile dysfunction is also common. It's happened in 1/3 of the patients after the MOGAD attack. And so, in conclusion, I have like a few messages that I want to take home. So first, spinal cord attack in MOGAD is often severe, but recovery is potentially good. And timely treatment is important, and it improves outcomes. And lastly, despite response to immunotherapy, residual bowel, bladder, and sexual dysfunction are very common after spinal cord attack in MOGAD. And now I am ready for the questions.
Thank you. Andrea Mitchell, MOG Project. So I've been having unexplained swelling with my legs, and my doctor's treating me with Lasix. But my question is, might I be having a spinal cord relapse?
So what happened to spinal cord relapse is when the muscles get weaker, and when the muscles get weak, it's very hard for our body to squeeze the blood back from the veins to your heart. This is why sometimes we can have fluid retention in the legs. It's not directly from MOGAD, but it's because it is secondary to muscle weakness, because it's very important to have a very good muscle strength. Very important to have a muscles working in order to squeeze the fluid back to the venous system and go up to the heart.
I'm doing physical therapy, but I find that it hurts more than anything to work out.
Yep. I understand that sometimes when our sensory pathways got messed up, it can cause some kind of like false signals, and it can cause pain. And the pain control is really important in MOGAD as well. And if the pain bothers a physical therapy process, we will need a better pain control.
Hi there. We have a community question. I just wanted to ask, this woman wants to ask if the patient has strange sensations, like their foot is vibrating. Would that typically be spinal cord activity or brain? And what about swallowing challenges? Where does that usually show up, and maybe how do you figure that out?
Sensory pathway is extend from the nerve receptors and go up to the brain. It can be either from spinal cord to the brain, but the patterns of the deficit can guide us where is the lesions, because we can say spinal cord is so organized and our brain is so organized as well. And for example, if we have both lower extremities, sensory problems, this can reflect like a spinal cord because it conducts the signal for the whole body. But if it happens in the brain, the symptom usually on just one side, because right brain responds for the left side of the body and left brain responds for the right side of the body. So this kind of finding can explain as well, and also MRI can help us to see where is the lesion to.
Great. Okay.
Great. Wonderful. Well, thank you.
Thank you very much.